And I'll try to stress some related points about exercise itself as being a significant part of the armamentarium of therapy. But I'll also then talk about specific contexts of administering exercise, certain circumstances where it should be thought about in the moment as a specific treatment, but then as a lifelong behavior that can modify thrombosis risks in a continuum, as part of a continuum of care. And you've been seeing this schematic and these principles of various contributors to thrombosis. And this is particularly related to thrombotic, thromboembolic disease, notions of venous stasis and vascular injury and hypercoagulability working together to predispose to thrombosis. And when one thinks about these things in various clinical contexts, the benefits of exercise become intuitive to some extent. The venous stasis issues are arising in part from a sedentary lifestyle, and we live in a time where sedentary lifestyle is endemic, with recreation focused on being at rest, work being behind a computer or a desk, and even travel where you're confined to tight spaces. Likewise with illnesses, with surgery, with paralysis, with body position and various immobilization issues. Vascular injury, certainly external vascular injury, if somebody has some physical injury to their body part, that's a risk. But as you've been hearing in the course of today, intrinsic vascular injury from cardiovascular risk factors, notorious risk factors that we think about in many cases in terms of our heart, really affect the rest of our bodies with things of issues of tobacco, diabetes, hypertension, obesity, various aspects of inflammation, and likewise issues of hypercoagulability, but focusing primarily in the first two is issues where exercise and aspects of activity can have very significant impact. So this is the substrate of vascular risk: obesity, sedentary life, various vascular risks are setups to the fact that we have thrombosis as such a large part of our medical challenge. So when one talks about physical activity, I wanted to start with a point that it has specific properties that are beneficial in modifying some of the risks, particularly venous stasis. So when one talks about muscle contraction as an aspect of physical activity, it really works in a way that's akin to compression therapy, pneumatic compression therapy, stimulating the blood flow and really creating like a pulsatile quality of physiology that does many advantages in modifying thrombotic risk. But then, as I've also emphasized, there are aspects that are more intrinsic where activity can modify some of the mediators of thrombosis. Intrinsic thrombolytic properties of plasmin and fibrinolysis are enhanced by exercise activities. And as you've been hearing with endothelial risk, the activity has benefits in modifying and moderating diabetes and hypertension, obesity, inflammation. All these things are improved by an exercise therapy or an exercise lifestyle. And I also want to just say these things in context of the greater benefits of exercise that are well promoted in vast amounts of literature in terms of the neurocognitive benefits of exercise, cardiac benefits, pulmonary benefits, metabolic benefits, skeletal muscle. By all accounts, exercise should be the thing that we all embrace as like the best thing that we could possibly do. And yet, ironically, it's not something which most people can adhere to. And we'll talk a little bit about that paradox. But as I've mentioned, exercise can be considered, and I believe promoted, as a very important primary prevention in specific contexts. So the notorious constriction that most of us experience in the course of being in an airplane, particularly long flights, have been described as a source of thrombosis risk. And this is usually in context of other risks. So it's air flight in the context of other risk factors that become synergistic in a way that's very detrimental to overall risk. So there are various exercises, not high intensity, just flexing and extending ankles regularly as part of a flight, walking at least hourly, maintaining hydration as a critical part of the hypercoagulability that reinforces some of the risks associated with stasis. So drinking plenty of fluids, but also avoiding fluids that are sources of paradoxical dehydration like alcohol and caffeine, avoiding constrictive clothing, avoiding sleeping medications to make you particularly sedentary. And these same types of concepts can be applied to a workplace or anything that puts you behind a computer for long periods of time. Now, many people were concerned that if they're experiencing thrombosis, particularly deep vein thrombosis, that if they get up and walk too soon, would that be a source of emboli, a source of pulmonary embolus, a source of instability? And yet this has been looked at in many studies, and it's shown that there is no overall increase in pulmonary emboli. The predominant benefits are positive, strongly positive. So as a method to reduce risks of thromboembolic disease, as a reduce risk of post-thrombotic disease, to reduce symptoms, to improve function, to return to work, all across the board, early mobilization as part of a hospitalization for thrombosis is a good thing. That's in general good for surgery, for cardiac disease, but the principle relates directly to thrombosis. I also want to emphasize the broader issue that I've already alluded to, but just to kind of give a little bit more substance, that we're dealing not just with clinical contexts, we're dealing with a broad conundrum that we live in a world where people are inactive. There are some components that are kind of obvious, but they're important to highlight. The population is getting older. There are more people who are overweight. There are more people who, as they are getting older, have more chronic diseases which become more encumbering in terms of their activity. So for these reasons, there's greater inactivity. This is a recent publication from Lancet, which shows by the various colors that there's, in America, about 30% inactivity, but it's even worse in other parts of the world. And it's getting worse. We're on a curve that's only getting worse. So then you think, as I've mentioned, some of the benefits, which are so strong of activity, and some, and yet the context where it's really not being embraced, why is that? So we've just been hearing from Dr. Fudi some of the aspects that contribute to poor adherence, and I'll talk a little bit about that. I mean, the irony is that most people have a very ambivalent feeling about activity. It's seen as work. Many people regard it as unsafe, particularly if they are older or overweight or have other types of limitations. And there's, I would argue, a very strong insufficiency of education. This again touches upon some of the things that Dr. Fudi just talked about. But in this case, I'm talking about exercise as a prescription. What is exercise? Where do you do it? How long? And I think these things really ricochet in people's brains, and they're almost too embarrassed to ask. And physicians don't take the time because they're too busy talking about the medications that we've just learned about. So it becomes a problem that involves both the physician, the provider, as well as the patient. And one can just turn on the TV or a computer or a newspaper to see some of the problem, because in many ways, we praise activity as part of our culture, but we praise a certain kind of activity. We see sporting events that are magnificent to watch, but I think in the experience of most patients who are dealing with all these types of impairments that I've alluded to, their exercise is intimidating. How could they possibly exercise like that? And it seems to be incredibly unsafe, which is true if that's what exercise is. So I would argue it's really fundamental to think about exercise in a much more rudimentary fashion. What is exercise? It involves specific things. So I have a conflict of interest here because I run cardiac rehab. So I think this is very important to talk about. I'm totally biased. And I think most physicians really don't share that bias. They just tend to say, go exercise, go walk. But it really becomes very confusing to patients. So it's aerobic. It's involving large muscle groups that drive the heart and circulation. It's strength, and involving muscle and skeletal tissue, and that reinforces the capacity for doing aerobic activity. It involves stretching, which provides joint stability and range of motion, which is really very much synergistic with the other types of activity I've mentioned. And it can be prescribed. It's a medication. It's something which is really important to administer in a very careful way. It involves issues of frequency and duration and intensity in ways that can be very understandable by a patient if he or she is given the chance to learn about it. And so, without going too much down this path, I just want to allude to the fact there are very specific types of exercise when one talks about administering activity that one can think about in terms of if someone is very impaired, 3 meds, and can barely even walk across this room. But that person's not too sick to exercise, they should exercise. Short bouts, multiple times a day. If they have a little bit more capacity, you can reduce the number of sessions, but you can make them longer. And if you have 5 meds, you can walk up or down a staircase, you can reduce the sessions to 3 to 5 times a week for 20 to 30 minutes. And these things have been thought out and tested. And only when you have the capacity for exercising about 20 to 30 minutes at a very low intensity should you then even begin to think about the intensity. And how is intensity administered? Well, I'm, again, biased. I do a lot of stress testing, and I think stress testing is incredibly valuable in helping our patients. There's a lot of literature now that decries the use of too much stress testing. It's not even it's not useful. It's been written about in the New York Times and other papers. I totally disagree. It's how you're using the stress test and what it's used for. It can be so valuable in giving a patient information about what he or she can do, what's safe, and helping the provider to guide them so they can exercise safely. And so we can measure the amount of oxygen they use and give an exercise prescription based upon that oxygen uptake, or the heart rate, or even the amount of exertion they feel as they're exercising. And we can very carefully prescribe exercise. And there are other ways to avoid such a formal prescription, which I'll talk about, but I really want to emphasize the value of exercise prescription from a medical point of view. And likewise, strength training, which is totally under-administered in my opinion, has enormous value. Not only in terms of force, like how much weight you can lift. That's relatively primitive, but it's how many times you can lift a weight before you're fatigued. That translates into how long you can walk, and how long you can carry on with your daily activities. And the power, how fast you can move. That translates into your ability to avoid falling and to maintain stability. So strength training lowers osteoporosis risks, lowers falls. It reduces the atrophy and the propensity to frailty with age. It increases metabolic rate, which helps with weight loss. Strength training is incredibly valuable and are used particularly in an aging society. So exercise, like aerobic training, like strength training, they can be administered carefully. We can talk about it with free weights. We can talk about it with weights in the gym that are a little bit fancy with machines. But you can also talk about it in terms of carrying groceries or gardening or lifting a gallon of milk at home. It can be done in a very accessible way for most patients if you take the time. Principles of warming up and cooling down are just as important, particularly for people who are dealing with frailties, with illness, who are insecure about exercise. Gradually exercising, working up their heart rate, working up blood flow to the muscles, particularly if you're older, particularly if you're frail, loosening your joints. This diminishes cardiac ischemia, it reduces arrhythmias, and when you're done exercising, having the same type of thought about slowing down, the cool down period. Reduces the metabolite, the lactic acid from your muscles. It reduces cardiac ischemia. These things can be done so safely for even the most frail adults. But as I've mentioned, I'm a believer in prescription because I think it helps people in the transition from illness towards a life where they can be very functional. So I really believe in that transition. But many people, many physicians, many patients say, I don't want to do that. That's not how I want to exercise. I just want to be okay, doc. So there are other principles. The physical activity guidelines for Americans, all ages, is to exercise about 150 minutes a week. So that can be broken down to several, minutes a day, 30 minutes about 5 times a day. There are different ways, you can add up to that. The points that are really clear is that even a little bit of exercise is better than none. Low intensity exercise has incredible value as compared to no exercise. If you can do more, higher intensity, that's better, but it really, the most critical part is starting. And if you really don't want to exercise in a setting where you have a prescription and you have people watching you, there are other things you can do. You can exercise to get short of breath, or till you can't talk. We call it the talk test. If you can talk, then things are probably physiologically fairly in equilibrium, and that's a fairly safe way of monitoring yourself. Exercising with a friend, the buddy system, carrying a cell phone. Those are very rudimentary things that patients can do. This study, which appeared in Lancet last year, it really highlights some of these principles. It had enormous visibility when it published. It came from Taiwan. And it showed, as you see here, the physical activity and duration on the x-axis relative to mortality. If you exercise for 15 minutes a day, 15 minutes a day, you reduce mortality 14%, you increase your life 3 years. 15 minutes a day. This is low intensity to moderate intensity exercise. This is walking for 15 minutes a day, having this powerful impact on your life. That's better than any medication I can think of in terms of the impact that what you could have, especially at the value what exercise costs. I mean, it has enormous utility. So how do you start? So I've emphasized prescription and doing this in a way that breaks down to a very understandable level along the ways that Dr. Fudi was describing. I've emphasized the utility of stress testing, but I've also said that for many people that does not seem comfortable, it's not really consistent with their goals. So there are many different types of styles of exercise, guided therapy being one, home training being another. People just don't prefer to come to a gym or a hospital or the equivalent. or just joining a class, joining the YMCA class in dancing or the equivalent. The best exercise is something a patient, we want to do. I would, again, acknowledging a conflict of interest, say consider cardiac rehabilitation, pulmonary rehabilitation, because these programs are very valuable in adjusting medications, the 8+ medications that most of our patients are on, along with guiding exercise, strength, aerobic. There's different frequencies of each, different elements, especially if you have arthritis or diabetes and all these other things that can complicate management. It improves adherence, and it has enormous value for various subsets of patients. It's notoriously underused. 15% in Massachusetts of appropriate patients are referred to cardiac rehabilitation. 15%. That's typical of the rest of the country. There are many reasons. The cost is prohibitive. We've heard about cost. The co-payments for cardiac rehab are just horrible. Transportation issues, convenience issues, these are notorious impediments. I would like to really emphasize, though, for anyone here, anyone administering patients that have thrombosis, that there are particular advantages. If you have recurrent pulmonary emboli, there's the association with pulmonary hypertension, which makes exercise much more difficult. If you have coronary disease, again, it's part of the substrate of thrombosis. You would likely have both risks related to coronary disease itself, but also heart failure and arrhythmias. And there again, guided therapy can be very useful. So in certain clinical contexts, making that extra effort for guided therapy, I think, is very useful. So what do you do? Just kind of summarizing, there's benefits for aerobic training. There's doing these things in a gym, in a medical setting, or even just a YMCA. Strength training, both of these things are usually done in association with stretching. Aerobic training is, as I mentioned, about 150 minutes a week, ideally. Strength training is usually about twice a week, much less time, and it can be done in a very prescriptive way. But the most important thing is increasing activity in general. And it's particularly important to be active, I would argue, if you have a propensity to thrombosis. If you've had it, you're at risk for having it again. And so exercise becomes even more important as secondary prevention. So I'm going to close with just a few moments of just describing just general tips for staying active. I've emphasized prescription, but just, in a very less sophisticated way to say, just squeeze a few 10-minute walks throughout the day. They're cumulative. It's okay if you don't have time for a full workout, because short bursts of exercise really translate into clinical benefit with blood pressure, cholesterol, sugars, energy levels all being enhanced. And you must avoid, I would argue, the all or nothing thinking. And activities like gardening, housekeeping, walking the dog, they count. They're beneficial. And you don't have to exercise strenuously to get benefit. You'll get benefits even much shorter duration, things that are fun. They really promote adherence, and they really are beneficial. Schedule exercise into your day. Start off slowly, modestly, pace yourself. Realistic goals, just a little bit of walking is fine. Keeping a log, going along with Dr. Fruiti's comment, is very helpful. But nowadays we have new toys that you can Google, and pedometers. Using your cell phone as an accelerometer, you can get feedback, you can get reinforcements. Because in our minds, I think most people think they've exercised a great deal when they've really barely walked across the room. So when you actually see the numbers, it's very useful. It's useful for you, it's useful for the physicians. Wake up earlier, go for a walk at lunch, take the stairs instead of an elevator. These things sound so easy, but most people don't do them because we believe in being sedentary. It's just part of what our culture has done. And I mentioned the use of a buddy system, just so it enhances behavior because you're with somebody. They're going to be annoyed if you don't exercise. It enhances safety. Joining a gym, mall walking. Actually, many malls now have groups, so there's a camaraderie. It reinforces the tendency to exercise. Parking further from the entrance and just walking in, so you have the need to walk. Walking around the mall or a shopping center before you shop, just so you know you've exercised. Or buying a video, or trying home equipment. These things are so accessible, but they're so underused. The most important thing is just not to sit and watch TV all day. So I hope I've given you a strong rationale for exercise and some tips to promote that. Again, I'd be happy for questions. Thank you very much.
Thanks, Dan. That was great. In the interest of time, if we can take one question and then move on. Dr. McDelly.
There was a report in the New England Journal last year about 3 cases of myocardial infarction in patients who completed the Boston Marathon, and we've also heard some cases of venous thromboembolism in highly athletic people. I wonder if you have any recommendations for a threshold for exercise.
Yeah, no, I think very, very high intensity exercise like marathons has more risk than the lower intensity exercises I've mentioned. In the article you mentioned, I mean, there's been concern about that, but again, you're talking about the very highest levels of exercise, and I've been really emphasizing lower intensity. High intensity exercise causes damage to the vascular tree. And if you there's a series of articles about doing a marathon even if you're fine, and then sitting on an airplane long thereafter, and that combination of things can really exert some stress. So I think there should be a healthy respect for the risks associated with ultra intense exercise, but a reassurance that low intensity exercise is quite safe.
Thank you very much.